A brief introduction. Professor Bridgewater is a medical oncologist specializing in GI cancers. He specialized in medical oncology at the Middlesex, Mount Vernon, and Royal Marsden hospitals. Dr. Bridgewater also holds a PhD in gene therapy from the Institute of Cancer Research, and subsequently he accepted a senior lecturer position in medical oncology at University College of London in 1999, along with a consultant position at UCL again. He has led and contributed to landmark studies in gastrointestinal malignancies, focusing on clinical and scientific research in GI cancers. His work includes chemotherapy, biliary cancer, bowel cancer, cancer of unknown primary, and liver cancer as well. He has also been involved in the personalized oncology treatment, targeting faulty genes in cancers with novel therapies. Professor Bridgewater also has served on several research and funding committees, including the Clinical Trials Advisory and Awards Committee, ASCO, INSERM, and the National Institute for Health and Care Excellence Committees. So welcome, Dr. Bridgewater, and looking forward to your session. Over to you. Thank you. And before that, I would also want to thank Dr. Prasenjit for allowing us to have this session virtually.
Thanks very much indeed. I'll just share my screen.
Yes.
Here we go. Fantastic. And so thank you. Is it on the screen share mode? It is now. Brilliant. So thanks very much indeed, everybody, for coming to this meeting. These are my disclosures. Huge apologies for not making it there in person. It was a flight issue. I would have loved to come to AIIMS to speak to you in person. I've heard so much about it. Please accept my huge apologies. We will do our very best virtually. Thank you very much, Bhavna, for sorting this out. Really excellent initiative. And I hope the conversations that will be generated in this session will continue, and we can build on them in the best academic sense. So this talk is about IDH1 as an agnostic driver, and it's really now increasingly special role in the management of cholangiocarcinoma. And it will be about some biology, some testing, and then some clinical outputs. My disclosures. So just a tiny bit step back, what does IDH1 or indeed 2 do? Well, you will all remember, I'm sure, that IDH is part of the Krebs pathway and is a key component in converting NADP to NADPH. In the IDH1 and IDH2 enzymes are essentially identical. The IDH2 is mitochondrial and IDH1 is cytosolic. The outcome of mutated IDH1 and 2 is identical. It's an increase in alpha-ketoglutarate, and the primary mode of cancer generation of this is methylation. Is methylation of the cancer nucleus, and there'll be some very interesting consequences of that primary pathological process. So here are the cancers in which IDH1 and 2 have been found to be mutated and plausibly driver mutations within those cancers. Glioma, intrahepatic cholangiocarcinoma, chondrosarcoma, angioimmunoblastic T-cell non-Hodgkin's lymphoma, SNUC, which is a small cell carcinoma of the nasal cavity, and AML. And these are the percentages of the incidence of these mutations. And you can see two things. You can see that it's really cancer dependent. Some cancers have a mixture of the two alterations. Some have more of one and more of the other. Some have none some have no IDH1 and IDH2 alone. So really, we say that these are tumor-agnostic genes. Of course, they're not tumor-agnostic. There's nothing tumor-agnostic about it at all. It's all the biology of the cancer in there as well. Tumor-agnostic is a useful way to look at the is a useful way indeed most of all for drug reimbursement. But biologically, it's a nonsense. There's no such thing as tumor-agnostic. So this is a somewhat misleading slide, you could argue. There are several incredibly interesting things about IDH1 and 2. For instance, the mutated partner of the arginine matters. So although this is looking at the little table here on the little graph here on the left, looking at IDH132 in IDH1 mutations, although the vast majority of these are IDH 132 cytosine. There are other partners of this, and those other partners have different levels of alpha-ketoglutarate generation. And so this leads us into the very interesting question: do some of these does an R132C mutation do better than an R132G mutation? Who knows? We haven't actually looked into that yet. That follows naturally onto IDH2 resistance, IDH1/2 resistance, and really, so if we and I'll give some examples here. So here we have a tumor report for a patient that I saw just the other week, and the little square on the left here is the tissue profiling. I'll go into that a bit later, and the thing on the left is a liquid biopsy. And as this is a mutation, actually either will do. And one of the outcomes of our study, which I'll show you in a minute, is a comparison of tissue versus liquid biopsy for mutations. Different question for fusions, as I'll go into. And the resistance is through the novel development of new alterations. So IDH2 mutations in IDH1 cancers, and that tells us that actually there are probably subclonal populations of IDH1 and 2 in pretty much all of these cancers, and we just haven't looked sufficiently thoroughly to get that out. This is a huge area of research currently. What about cholangiocarcinoma? So I'll go through a few of the cancers. Cholangiocarcinoma, mostly IDH1. Arguably, IDH2 is the poor cousin here, really, representing a relatively small number. You'll see that the pathology, alpha-ketoglutarate generation, is the same in both. And really, this is the big story of IDH1 and 2, which I'll develop a bit more on a bit later. We've known this for a while, of course. This is the original TCGA data, in fact, mostly done in Singapore, where I am at the moment, curiously. And it shows that you have a methylated population of patients, fluke negative and intrahepatic, as you would expect for IDH1 and 2, and they are all hypermethylated, and they perhaps have a better outcome. So it's the IDH1/2 story fits in very nicely with what we know on a preclinical basis. There's not a lot in the way of co-alteration. So much so that if you find an IDH1 mutation, I don't normally bother to look too hard for another alteration. In fact, it isn't shown on this slide, but the only other alteration to look for if you find an IDH1 and 2 is HER2. That's the only one that coexists. But generally speaking, you can see on the circus plot here the primary co-occurrent alteration is ARID1A, for which we haven't got any drugs at the moment, and potentially EGFR. More on that later. What about this incredibly interesting cancer, small cell nasopharyngeal undifferentiated carcinomas? So IDH2 alterations throughout. You get a pattern of IDH2 arginine 172 alterations, copy number all over the place, and really these would the use of IDH2 drugs in these cancers hasn't happened yet. The use of IDH2 identification is more a diagnostic thing, and consequently maybe of interest to you. But really, no treatment has taken hold yet, and arguably because there isn't a drug. More anon. In glioma, IDH1 is used more or less as a diagnostic process. Again, very little treatment. Very little in the way of treatment has happened, and so it is more diagnostic, and you can differentiate IDH1 mutated gliomas from other potentially less good prognosis gliomas. It's primarily IDH1, just a smattering of IDH2. Chondrosarcoma, again, you find a similar picture where it's predominantly IDH1, and there have been some treatment protocols started primarily by Servier, actually, looking at this. But these are really difficult cancers to treat, and they are, if anything, much less common than cholangiocarcinoma. And so, this story has yet to develop. And finally in AML, once again, this is more of a diagnostic process, the identification of IDH1 mutations. It's in AML that we have the most information about resistance. So it's very clear, the bottom two panels here, that IDH1, that novel IDH2 alterations will be the primary resistant emergent alterations that you find. And we can discuss later, if you wish, the role for sequential liquid biopsy in doing this. So let's go back to the most well-documented story as far as this is concerned, which is the cholangiocarcinoma story. And so once again, a step back. You'll know this as pathologists, but maybe there are a few variations of interest. So cholangiocarcinoma and gallbladder cancer, cancers arising from the biliary epithelium. And this is either in the mass of the liver, which are the intrahepatics. At the hilum, these are now known in the WHO ICO classification as perihilar cholangiocarcinomas, we should call them. Those distal cholangiocarcinomas arising primarily in the body of the pancreas, and then the gallbladders. And they, roughly speaking, certainly from the surgical series, split up roughly into 4 equal cohorts. In the advanced disease medical oncology related studies, it is primarily intrahepatic, and that's really got to do with a prognostic and potentially treatment related agenda in terms of how they split up. And we've known for a while that the incidence is going up. So these blue squares are pancreas, the blue triangles is cholangiocarcinoma, and this is primarily intrahepatic cholangiocarcinoma. And it's not just in the UK, that's on the left, but also in the States. And so consequently, this really is something that I'll go on to some etiology a bit later on. This is something that we are doing to our livers. This is very similar. The etiology of intrahepatic cholangio is very similar to that of hepatocellular cancer. And so, we are doing something to our livers to do this. What is it? Who knows? There are all sorts of hints as to how it can be related. So, why do we get young women with intrahepatic cholangiocarcinomas, which are larger, which in my constitute a large proportion of my practice? And we are really terrible at treating these cancers, absolutely appalling. The majority of the patients present in A&E. So on the left here, you can see the MMF data. So that's the charity in the UK has done a lot of work looking at the incidence, and you can see it really hasn't changed over the last 10 years or so. About 50% of patients present in A&E, by definition symptomatic and really not very well. And the other set of data is that only about 50% of them receive any treatment. Now, we've all come across the elderly jaundiced cholangiocarcinoma patient who should not be treated, but 50% is really high. And looking into that and why people don't get treatment is a big story. It's not just the UK. So these are French data from Cindy Noisile, looking at cholangios, and the numbers are incredibly, embarrassingly similar. So the vast majority of patients, a large number of people present in A&E and get supportive care alone. Interestingly, if you turn up at a general hospital, you are much more likely to get a management which is supportive care rather than in private practice or in a cancer center. So that speaks to a huge education issue that we have here. And over the last 15, I dare say 20 years, myself and my colleagues have established the systemic treatment care, both in the adjuvant setting, that's the BILCAP study we published a few years back now, with capecitabine, the first-line advanced disease study, ABC2, only recently superseded by cisgem durvalumab or pembrolizumab. There's the TOPAZ one, and second line treatment with FOLFOX. You can see, however, that outcomes are still pretty miserable. If you have adjuvant treatment, you're actually still quite likely to relapse. If you relapse, you don't have, your survival is roughly slightly over a year. And second line treatment, the survival benefit is unbelievably modest. I offer FOLFOX second line treatment to my patients as an option, not as a strong recommendation as a result of this. And more chemotherapy and more targeted therapy is unlikely to help. Here are some of the trials that have been negative and using either more intensive chemotherapy or cisgem plus something else. All of them negative. Maybe the one that got away was ABC3. Had we done a larger study, that may have been positive. But this suggests that keeping plugging away at chemotherapy and chemotherapy plus is not going to get us anywhere. In contrast, the huge excitement is around the genomic treatment of biliary tract cancer. And this comes mostly from the TCGA data. And the TCGA data tell us several things. Firstly, it tells us that there are a lot of alterations in biliary tract cancer. It tells us that they are anatomically distinct. So the fusions tend to occur in the intrahepatics. The IDH1s tend to occur in the intrahepatics. There are some pan-biliary alterations, such as BRAF and HER2, but really it's very, very difficult to be categorical about where your alteration arises from. They do appear to be mutually co-exclusive, as I mentioned earlier. So if you have, for instance, a RAS alteration, it's about 1/5 of these cancers, you haven't got anything else. you'll never have a fusion, you'll never have an IDH1, or incredibly rarely have an IDH1 mutation. When I find a patient with a RAS and FGFR2 fusion, I know that I'm dealing with two cancers, not one. And the real benefit for precision medicine in these patients comes originally from the French data, the Moscato study. So Moscato was where over 1,000 patients got a test. Actually, it was a fairly cheap and cheerful Tempus test that the Gustave Roussy had running at the time. But they tested over 1,000 people and just paired them up with anything they could get their hands on. And out of those 1,000 people, there were 43 biliary tract cancer patients. And the Moscato study told us two things. It told us, number one, you were more likely to find an alteration in biliary tract cancer. So out of 43 patients, there were 23 alterations, so about half, compared to maybe a fifth in other cancers put together. And if you were treated, you were more likely to respond. So instantly, this puts biliary tract cancer into, actually, in my view, a very special field. And what were those responding alterations? Well, here they are. I actually communicated with each of the physicians who looked after these patients to find out what they were given. And they were given a number of, they were given whatever they had their hands on, and arguably not actually the best treatment, or indeed the most modern treatment. So, but this was a big clue that something works here. And sure enough, over the last 7 or 8 years or so, we have really compelling data for IDH1, BRAF, and FGFR2, and actually most recently, I haven't got it on this slide, but both TDXD and zanidatamab for HER2 alterations. Just a word about the IDH1 study. So this was the Clarity study that we ran, I guess about 5 or 6 years ago now, which randomized patients between ivosidenib, that's an IDH1 inhibitor, and placebo, and it was a positive study. And on the basis of this, ivosidenib is licensed and has an EMEA FDA license, and is also NICE approved in the UK. And that's great for these patients a bit more later. You will see from this, however, that a significant number of patients, arguably something like 40%, do not benefit at all. So that tells us, in fact, IDH1 is a key biomarker, but it is way the not best biomarker. We need to improve our test here. So that obviously clearly requires a bit more work, but we can do. We definitely need a better test. I'm very happy to discuss that offline with people if they so wish. Here's the overall survival, complicated by the fact that this study permitted crossover. The patient groups insisted on crossover and obviated a true survival outcome. But you can make calculations, and that's the placebo outcome, but you can make a calculation that says that if not treated with ivosidenib, your placebo outcome would have been very much worse. And you can get an overall survival of around about 10 months with this. Interestingly, the later data, so this is new, this is real world data, the PROVIDE study where everybody got everybody got ivosidenib. The overall survival was 15 months. So these are pretty hard numbers, 10 months, 15 months. And so the overall survival is improving over time. And the only explanation for this is actually that we're getting a bit better at this, in that we are identifying patients sooner and we're getting them onto this treatment sooner. So, it is so important to identify these alterations. You know, I can tell my patient with an IDH1 mutation, fabulous, great news. You know, this will give you another year and a half, something like that. And if I'm able to tell my patients that, that's great for me because, you know, I've given chemotherapy for 30 years. I haven't been able to say that. But with this stuff, I can. And that's really, really great news. For testing. So when to do the testing? This is a much mooted question. And what testing? And I'll go into that a little more. Let's skip over that. So in the UK, we have 7. They're listed up on the left here. 7 what we call genomic hubs, which are central labs where all the tissue gets sent for testing. The tests that they use are vary slightly, but in fact, I've looked into it. They're all variations on a very old Roche test that's been developed and modified over years, and they together with some form of RNA sequencing, mostly TS500 RNA sequencing. And so every sample that goes to one of these labs in the UK, if you write cholangiocarcinoma on it, the code is M220, I happen to know that, you will get the results of, you will get a fusion result looking at NTRK, FGFR2, ALK, and MET and ROS, and you will get a DNA result, IDH1, BRAF, and a few other things. And this is specified in this beautiful document called the National Directory. And these labs have a statutory requirement to report these for you. They don't report anything else, and they report these because there are nice guidance supporting the benefit and the use of specific drugs for these alterations. And this is really, really important, and should really have transformed the way we do things. It does in some ways, it does not in other ways. I will expand. Here is the example of a case who had a patient, in fact, a Romanian patient who came to see me, metastatic intrahepatic cholangiocarcinoma to liver, and had progressed on standard of care treatment. So his survival was going to be 3 months or so at best. And he had these are foundation tests, you will be able to spot that. And he'd had both a liquid biopsy and a tissue biopsy. And on both of these tests, a BAP1 alteration came up, just BAP1, nothing else. And he came to see me, and I thought this was somewhat odd because actually it's very unusual to get BAP1 by itself. And I also happened to know at the time, they've changed it now, but Foundation did a standard hybridization DNA test. It was not RNA sequencing. And we know that if you do a DNA test, you will miss probably about 1 in 3, 1 in 4 fusions that are out there. So I got him to bring his biopsy to central London, and blow me down, he had a fusion that was picked up on RNA sequencing and not on the 2 foundation tests. And this makes sense because FGFR co-occurs with BAP1, I happen to know that. And he went on to study drug, the relay drug, and he was in complete remission for almost 2 years. He's now relapsed and he's on other things. But, you know, this repeating the right test, I think is the only way of putting it, has given this man an extra 4 years of life. And that I don't think you can say that very often. Us oncologists cannot actually say that very often. We're still rubbish at it, though. Here are some numbers, and I'll run through the numbers from the top here. So the patients with a cholangiocarcinoma diagnosis in the UK. So there are some numbers here. I reckon they're all still underestimates, but here they are. So in one of the COVID years, we were allowed to get anything we wanted. They let us get data from any, virtually any source. And so 2,900 patients, that's the top number here, patients were admitted to hospital in 2022 with a diagnosis of cholangiocarcinoma. The numbers from the AIIMS, that's the charity group analysis, are really very similar. We reckon that's an underestimate. In the UK, whenever we prescribe an expensive drug, we have to fill in this online form called BlueTech, and 1,144 patients had a BlueTech request for first-line development, for first-line immunotherapy. So those are the patients who are actually treated first line. So there's your first huge drop, diagnosis to treatment. I also know that the number of requests, the M220, the number of requests for genomic profiling that went through the whole program was very similar to the request for DERVA. So I guess the easy conclusion from that is if you had first line treatment, somebody would have had the sense to do a test on you. The anticipated number of IDH1 mutations from 1,140 tests is about 148, but we also know from the evosidenib expensive drug request that only 29 patients had a request. So that's the second drop. We're probably treating about a quarter of the patients we could with targeted therapy. And so here, my overwhelming impression is that there is a huge education piece to be taken care of. We're taking this forward. So this is ABC10. I described ABC2 to you, which is the first-line advanced disease study. ABC10 is a targeted therapy study, and it's really very simple. On the left here, on the right here, sorry, patients are consented for profiling, so we send it off to the North Thames hub, which in fact is at the Marsden, and simultaneously they have a liquid biopsy. While these results are processed, they receive their 4 cycles of standard of care treatment, and then they're randomized to targeted therapy. Here's a list of the usual suspects on the left here, or standard of care treatment at 12 weeks. And then they can cross back over to the other arm if they need to. And so this is an umbrella study, but it's critically dependent on the quality of the testing. And I said earlier to presentation, one of the very interesting outcomes of this study will be actually a comparison of tissue versus liquid biopsy, and also the value of and how we're testing it, and how to get the best out of that. But as you can see from the case presentation I presented earlier, it is absolutely critical not to miss one of these alterations. And this is how we're doing. So the gray line is the expected, and we're on the green line. So we're recruiting well ahead of our schedule, and indeed will be finished probably 12 months ahead of time. So it is, I think, big message here is that it's possible to do studies in this rare cancer. Here's what we found. So about 1 in 3 people have an actionable alteration, and that's quite good, I think. Not all these patients are getting randomized because primarily because of disease progression, but this is what we're finding. And the perceptive people in the audience will actually think, this is a bit of a mess here, isn't it? Because for the FGFR2s, you need RNA-seq. For the IDH1s, you need a DNA panel, and for HER2s, for HER2 amplification, you need HER2 immunohistochemistry. So you need 3 tests. It would be fantastic, and for a long time I plugged away at this. If we could use one test to rule them all, just one test that would tell us all the answers to these things. But there is no such thing. Currently, we have to do 3 tests. But it's going well. And as I say, one of the really interesting bits about this paper will be how the testing works. And that's absolutely critical. The other spin-off, I think almost even more important spin-off of this program, is the development of other studies. So we, as well as the main program on the left here in green, consequent on all the results that we're getting out of the testing, where we've developed an IDH2 study. We're in the process of developing BAP1 and RAS studies. There's a radiation study and there's an immunotherapy study. So this is what umbrella studies are supposed to do. They're supposed to generate novel concepts and interests. And fortunately, the ABC10 program has done that. This is another really interesting bit of it, the conversion to surgery. So you might expect this, because the response rates with these targeted therapies are 2 or 3 times better than that for chemotherapy. So some kind of conversion to therapy might be interesting, might be possible. So far, we've collected 8. Apparently, there are some in an American study that I haven't managed to get my hands on yet, but it's not bad. All of these patients progressed on first-line therapy, and they've all been treated with between 3 to 31 months of FGFR2 inhibitor. 8 operations, 2 pathological CRs, 3 have relapsed, but they're all alive and doing really well. So this conversion story is going to be huge. I'm sure it's going to be absolutely massive. And then finally, this is the final sort of talking slide I have here. How am I doing, Bhavana? Just over half an hour. Good. This is the final talking slide here. This is what I think is happening. And we have to really begin to design our studies and our strategies and our testing and our thinking around these models. If you take the top half of the slide first, if you look at the intrahepatic tumors, the cell of origin of the cancer here are small cholangiocytes. And in the context of the known etiologies, so anything that damages the liver, and we know what those things are, you get a number of key high-pressure genes which mutate and become drivers. And there are a number of these. If you take the example of FGFR2, you can have a number of different forms of overexpression of FGFR2. I didn't go into that, but in ABC10, we're permitting treatment of all of these. Actually, the label is currently only for the fusions. In my view, it should be for all of these. If you give them FGFR treatment, you either get a further alteration in that gene, just emphasizing how important that gene is. But you also get other mutations as well. So the subclonal, this is what my colleague Charlie Swanton has said for many years, targeted treatment is rubbish because you just get the emergence of subclones. Well, yes, of course he's correct. But actually, if it takes you 2 years to do that, that's not such a bad outcome. If you look at perihilar cholangiocarcinomas, the story is quite different. Here, you have larger cholangiocytes as a cell of origin of the cancer, and the stimulus for cancer is primarily inflammatory. So PSC, anatomical alterations, liver flukes, gallstones. And here you get a slightly different pattern of alteration here, making these perihilars more difficult to treat. So this is what I think is going on. I think it's a fascinating story. And, I'd be incredibly interested to continue this conversation with you, with any of you offline as required. I think it's a real, I love it. I love it. I think it's great. So on that note, just a summary of what I've said. I'm really looking forward to the discussion. IDH is a tumor-agnostic actionable alteration. I've said that actually probably wrong. It's not tumor-agnostic. It's very tumor-specific, but let's just stick with that. We're terrible at treating it. There's a huge shortfall in deliverable treatment, both in terms of standard of care treatment and targeted treatment. The big message here is education. The standard of care is established. So that's cisplatin, gemcitabine, and durvalumab. But currently, there's no enrichment of these. You give immunotherapy to everybody, but only about 1 in 10 benefit. It's not great. As I said earlier, you need 3 tests. I mean, it's a pain, but currently that's the situation. You need a DNA test, an RNA test, and immunohistochemistry to identify all the potentially treatable options. All these targeted therapies are going to move into neoadjuvant and adjuvant spaces. We have an adjuvant study planned. I showed you some of the neoadjuvant data. This is where it's going to go. And we know targeted therapies are going to be much better in the earlier the cancer, when there's less likelihood for resistant subclones to emerge. And we can recruit into trials. ABC10 will finish a year early, and maybe the next time I speak to you, it will be with some further information from that. So on that, these are all the people that fund me and help me. Thank you very much indeed. Thank you very much, Bhavna and President. And I'm really looking forward to taking any questions. Thank you.
Thank you, Dr. Bridgewater. That was really very comprehensive and very enlightening. And you mentioned IDH1 mutation study is not only has a actionable, it is one of the actionable targets, but it is also valuable from the prognostic point of view. I think Dr. Chetan is there, who is our medical oncologist looking after GI malignancies. Dr. Chetan, can you join in the discussion? I don't know if he is free or not. Dr. Chetan?
Yes, sir.
Yeah.
That
Yeah,
was
yeah. Please carry on.
a nice presentation which covered everything. And thank you, Dr. John, for having such a nice presentation. As sir told, IDH mutations are actually very rare in cholangiocarcinoma. In our cohort, it is around 4 to 5% of the patients of cholangiocarcinomas have IDH1 or IDH2 mutations. More common is IDH1 mutations, and they are actually less responsive to chemoimmunotherapy. As I told, 1 in 10 patients only respond, and even 1 or 2 patients we gave ivosidenib, and the response was dismal. Almost all patients succumbed to their disease in 4 or 5 months. So generally, currently we are doing for all patients IDH1 and 2 mutations through NGS, and looking forward for further data on this.
Yeah, I mean, what you've just said very much echoes our original early experience with ivosidenib when we started to use it. Actually, I think we're getting better at it. We're doing the test earlier. We're identifying the patients with a smaller disease load. They're getting treatment earlier. And that's reflected in the overall survival numbers between the original Clarity study we did, 5 or 6 years ago, and the Provide study, which we did last year sometime. 10 to 15 months. Overall survival, pretty hard endpoint for this dismal outlook group of patients. So what you've just said very much reflects what some of my colleagues in the UK said when ivosidenib was first introduced. Do not be dismayed. Do not lose hope here. There will be long-term responders. There will, the benefit of this stuff I think is huge. It's game-changing as far as I'm concerned. So do not dismay. Keep looking for it. Even though it's going to be a relatively small proportion of your patients, the identification of an alteration for some people will make a life-changing difference. Really, really important.
I think, Dr. Chetan, we need to start this in-house. and we have been planned to start oncomine focus sequencing gene panel study. We are actually doing that for some other cases, so we can discuss that. Dr. Bridgewater, you discussed you also a subset of the patient, you followed them vertically for identification of passenger mutations. After how many months or so you looked for these passenger mutations? What is your experience?
Yeah. So the emergence of so these patients are either fall into one of two groups: primary and secondary resistance. Primary resistance, I showed you on the Clarity study, is around about 40%. So you get a big drop off right at the beginning. Secondary resistance, the development of subclones of IDH2 or other alterations in IDH1, will develop over 6 months plus. So there's a group of these people who do well, and whose disease progression is primarily related to the development of novel alterations, or the development. We are almost certain the emergence of subclones within the cancer, but that takes time. That's 6 months plus, and that happens with all of these. It's not just IDH1; it's FGFR2. The HER2 is even more interesting. So, as we know, HER2 resistance in breast is because you just lose the HER2. In this, it's not. I've done repeated HER2 immunohistochemistry on patients resistant to HER2 drugs, and they retain the 3+. There's something else going on that we don't know about. It's incredibly interesting. There are a couple of questions in the chat. Would you like me to deal with those?
Yeah, please.
Are there any morphological clues in biliary tract which can help identify the IDH1 mutations? Not that I know of, but it would be strange to give a talk in 2026 and not mention AI. And now, as part of a UK initiative, we are scanning all H&E new cancers that come into the department. It's not for all cancers. I'm getting it done for the ABC10 study patients, but at some stage, these H&Es will go into a big machine that goes bang and pop, and potentially be somewhat better at identifying IDH1 mutations than a DNA assay. The second question is around immunohistochemistry. I think immunohistochemistry should be superseded now by a standard DNA test of whatever way you like. IDH1 is a mutation. You don't need RNA-seq so long as your DNA is of reasonable quality, and it hasn't been in paraffin for too long. The result is between is very dependable and can be relied upon. So in my view, you've got to do the NGS.
And I think the mutation is also slightly different. The antibody was for the gliomas. It was grown for R132H. I think it is more here at R132C or something else. So it may not be very reliable.
Yeah.
Do you have any other questions from anyone? Dr. Mukuldeep Roy is also there. Dr. Chetan is there. Other pathologists?
I'll just relate that while they're thinking, I'll just relate a story that I told a bit earlier about the importance of testing here. So in the ABC10 study, we've now tested over 500 patients looking for alterations in over 500 patients. We've found about 85 IDH1 alterations, all R132 alterations. during one of the molecular tumor board meetings, incidentally, one of the best attended meetings ever, another slightly strange alteration, I think IDH1-115, something, I'm sorry, apologies, I've got that wrong almost certainly, came up. And I said, oh, well, that's rubbish, isn't it? And the molecular scientist turned around to me and said, no, that's a driver alteration. And then somebody else said, oh, yes, it's a driver alteration in hematological malignancy. And so one big consequence of the testing everybody that we have is the finding of new cancers. So, you know, we are, and that will, I hope, be one of the more, I hope, interesting outcomes of the ABC10 study, N equals 800. We'll be able to say, you know what, we found 10 new cancers here that were subclinical, nobody ever knew anything about. And you can do that just on your bog standard NGS test. I'm pretty impressed by that. I don't know about you. You guys probably do it every day, but I find that very impressive.
So if there is no other question, I thank you again, Dr. Bridgewater, and I hand over to Bhavna to wrap it up.
Yeah. Thank you. Thank you, Dr. Prasanjit. Thank you, Dr. Bridgewater, for a very lucid presentation. I'm sure this will, help deepen the current audience's understanding and appreciation of how IDH can shape the future research and the clinical practice in GI oncology. What is the biological impact of IDH mutations in GI malignancies? And thank you again, Dr. Prasanjit, for helping us organize this. So if there are no more questions, we can close the session. Thank you so much.
Thank you. Thank you so much.
Thank you very much, everybody, for your attention. Huge pleasure. And if you want to continue any of these conversations offline, please get in touch.
Yeah. Thank you so much.
Okay.
Thank you. Thanks. Bye-bye.
Bye-bye.